This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker for this evening, we'd like to give an overview to those that are joining for the first time. First, briefly, who we are, what is our program, some upcoming events. We'll then introduce Dr. Brad Tinkle, our speaker for this evening, and as I mentioned earlier, no Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 70 groups to date. Each group is given their own free website with a link from the directory and map. We received feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly webinar fees. Please visit our store and check out the helpful products that we sell. Just a brief disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Upcoming events, webinars, date Tuesday, June 2nd, 2015. Dr. Theo Herides presents mast cell disorders. Dr. Theo Herides is the director of the Molecular Immunopharmacology at Drug Discovery Laboratory. Note, in 2015, our webinars have been moved to the first and third Tuesdays at 7:30 p.m. Eastern Standard Time. You can read more details on our website. Just a reminder that May is EDS Awareness Month. Consider doing an EDS awareness activity in your local community. Participate in an EDS/Chiari walk. More at our website or www.csfunite/night. EDS awareness shirts are available for $10 each at www.bodysupportstore.com. Unfortunately, we will not have a Q&A session tonight, but the session will be recorded. The recording and slides will be posted on our site tomorrow. Dr. Brad Tinkle. Our speaker tonight is Dr. Brad Tinkle, and his topic is Introduction to Ehlers-Danlos Syndrome. Brad T. Tinkle, MD, PhD, is the Medical Director of Clinical Genetics at Advocate Children's Hospital in Chicagoland. His clinics include Ehlers-Danlos for adults, children, and families, and pediatric Down syndrome. Prior to his current position, Dr. Tinkle was a clinical molecular geneticist at Cincinnati Children's Hospital Medical Center, CCHMC. He specializes in caring for individuals with heritable connective tissue disorders such as Ehlers-Danlos syndromes, Marfan syndrome, osteogenesis imperfecta, and achondroplasia, among the many. And Dr. Tinkle served as director of the Skeletal Dysplasia Center, CCHMC, co-director of the Marfan Ehlers-Danlos Syndrome Clinic, as well as director of the Connective Tissue Clinic. He serves as Associate Director in the Clinical Molecular Genetics Laboratory at CCHMC. Brad T. Tinkle, MD, formerly served on the Board of Directors and on the Professional Advisory Network of the Ehlers-Danlos National Foundation. Welcome, Dr. Tinkle. We're looking forward to hearing your presentation, and you will see your slides loaded on the screen. I'm turning over the microphone to you now, Dr. Tinkle.
Well, thank you, Donna. I appreciate that. Good evening, everybody. I was asked to present sort of an overview of Ehlers-Danlos syndrome. Sometimes we'll call them Ehlers-Danlos syndromes, because as you can see, there's multiple types, which in essence are syndromes of themselves. So it will be somewhat brief over some of the rarer types, go into some more details of the more common or major types. At the end, we're going to talk about what primarily affects hypermobile EDS, mostly because that is where we have most of the information. As we look at some of the other forms, there seems to be a lot of commonality amongst the other forms. So I think once we get organized and start asking the questions of these other types of EDS, we'll find a lot of similarities, which means as we grow greater understanding of hypermobile type, I think it will broaden out to the other types. So let's get started. So it's hard to talk about EDS without talking about joint hypermobility. And by definition, what we're talking about is generalized joint hypermobility. In other words, any one person could have a joint that seems to move in greater range than the normal population. So that would be joint hypermobility. Generalized just sort of indicates to us that there's multiple joints. And one way that we assess the number of joints, and particular what we call small and large joints, is using the Beighton scoring system. So the Beighton scoring system, as sort of depicted here, basically includes a couple simple maneuvers easily done in a clinic office. Matter of fact, it was described out in the bush country in Africa. So it was meant to be a simple, quick exam, no equipment or anything else. What it involves is whether or not a person can essentially bend their pinky finger back so that the degree between the pinky and the back of the hand is less than 90 degrees. And they put their thumb to their forearm Does their elbow and knee extend backwards greater than 10 degrees, and can, from a standing position, knees straight, able to place hands on the floor. So that is the Beighton scoring system. There are many issues that come about by using this particular system. So the possible score is 9. That includes right and left. One has to remember each side may be different. It is not uncommon to see a difference between the dominant and the non-dominant side. But also think about people who have had either extensive injury to one joint or even a knee replacement that alters the score. And unfortunately, the scoring system was not designed to take a lot of those things into account. So it doesn't take age into account. It doesn't take racial or ethnic background. And you'll see that has an effect. The other thing is, in EDS, we tend to use a cutoff threshold of 5. But in other systems, you'll see that the cutoff score is a little bit different. So unfortunately, it's actually a very good clinical exam tool, but it falls short in many categories to the point that many feel like it is not the system to use. But unfortunately, they haven't proposed a better system. So these are some of the factors that influence this. I've already talked about these. Age. You are most likely the most bendable shortly after birth and decrease thereafter in generality. Gender. Females are inherently more bendy than males, and I'll show you that data. Ethnicity makes a difference. Obviously, if you do a certain profession, you can increase your limberness, essentially. But also conversely, we see plenty of people who may, for example, work very hard with their hands and lose the hypermobility in their fingers. So we can see that profession or training affects both negatively and positively that score. While we talk about the Beighton criteria, there are several other criteria that's actually out there. Carter-Wilkinson is one. And the Beighton criteria was kind of part of a derivation of the Carter-Wilkinson, and there are a few other criteria that have been proposed. And I mentioned the threshold. This was, I think, a very nice study that came out of Cincinnati Children's. Essentially, what they offered to middle school and high school athletes was if you came in to this sort of an exercise movement biomechanical lab, they would give you your pre-participation sports physicals. So you got something, and they got some research. And their hypothesis was that people who had knee hypomobility or knee laxity were more prone to injury, especially with jumping sports. So a lot of it was basketball. And so that meant they had a lot of people who come through, literally thousands of kids that come through, and they measured the generalized joint hypermobility using the Beighton scoring system. So in the general population, which is in this case Midwestern, primary Caucasian, some admixture of Hispanics and some admixture of African Americans, the average score from males and females as children, so before puberty, really was not significantly different. Yet when they started to go through puberty, there was a significant change. Now, a 2 to 3 may not sound like it's a big change, but over a general population, the obvious trend was females seemed to get somewhat looser and males seemed to get somewhat tighter. So we call this a sex or gender influence trait, where being male or female happens to affect the particular feature that we're looking at. And we strongly believe that this is based in hormones. There is some data, but not really clear, but it is a strong belief that it really sort of stands that the hormones have an effect on collagen, which have an effect on hypermobility. So looking at the Beighton score, we can see the difference between the two populations. This is somewhat similar. This is ethnicity, looking in different countries, their percent across a sort of a general population. And you can see there's some variation of who meets generalized joint hypermobility, up to 20% in some populations. But typically women are more have a greater chance to have joint hypermobility than men. The scoring effect is also something that is significant as well. So on the left hand, there's two studies out of India. They both looked at school children. The age range was a little difference between the two studies, but one used a cutoff of Beighton score of 4, and one used a cutoff of 5. And so obviously at 4, you captured more individuals, and that was roughly 60%. If you went up to 5, that was 40-ish%. Now, this is not the same population, so it's not the best study in comparison. However, the study from Second et al. Actually got to that point very specifically. It looked at 800 Turkish students, adolescent age, and basically broke them down. How many met criteria at Beighton score of 4, how many met at a 5. Now, the reason why this is important is because some people use a different cutoff, and therefore we're going to include more people or exclude more people depending on where we use that cutoff. And so that is something that you'll see that there's a slight difference of how this is used in the diagnosis. What is one of the concerns about having joint hypermobility? So the first thing is, is it somebody who just has joint mobility and no other issues? What we'll call benign joint hypermobility. Not benign joint hypermobility syndrome, just benign joint hypermobility. Versus somebody that has some other process. So you want to differentiate the people who have problems from the people who don't have problems. But joint hypermobility is not unique to EDS. It is included in a number of genetic syndromes. OMA and McCossin are two sort of genetic databases. And you can see joint hypermobility in one database was included in 66 different syndromes and another 319. If you consider people with low muscle tone, they have also a reason to have joint hypermobility. Their muscles don't control their joints as well, and so their joints can move in greater degrees. That would be literally hundreds more of people who could have joint hypermobility based on low muscle tone. So we're primarily, when we're talking about EDS or connective tissue disorders, we're really talking what we call ligamentous laxity. Ligaments are the strong connective tissue bands that essentially join bone to bone to sort of limit the movement of one bone against another, i.e. limit the movement of a joint. So the important thing is to see if we can distinguish somebody with benign joint mobility, but can we also pick out people with maybe EDS or the different EDS types versus other conditions such as Marfan syndrome or osteogenesis imperfecta, etc. The Australians have an approach to this I thought was very interesting in that their question wasn't so much initially how to sort of bin them or characterize them. It was to how do we assess so that we capture all the data we need to make sure that they're appropriately classified. And so they took the hypermobile child and they looked for certain things. They looked for eye problems, which could signify Marfan syndrome or Loeys-Dietz. They looked at the heart, that could also signify Marfan, Loeys-Dietz, some other things. Take a history about bone health. Could that be osteogenesis imperfecta? So they looked at it that way to see if they can come down to a particular diagnosis. But on the other hand, what they also realized was no matter how you bin those people, how you categorize those people, there was a lot of commonality to the people who had joint hypermobility. They had unstable joints. They had soft tissue that was constantly under strain. They had muscles that were overused and painful. A lot of people would have chronic medical pain and complaints and et cetera. And so what they wanted to really not get hung up with is not to sort of necessarily always come with a solid diagnosis. They wanted to look at it as, what are your problems and how can we help with your problems? And that's more of an approach as a clinician, whereas sometimes I think we get stuck more in a scientific mode of, well, what this is and how can we prove it's one syndrome or another, and we get lost sometimes without thinking how we can help the actual patient. So this is a talk about Ehlers-Danlos, so let's talk about that in more detail. So the commonality amongst them is the connective tissue disorders. They tend to have skin and joint hypermobility, and as we go through them, you will see a number of things that are common, but things that actually make each type somewhat unique. There are other syndromes that we can call out. They're not EDS, who have a lot of similar things, but maybe somebody had characterized them as another condition, and therefore we don't call it EDS, we call it some other syndrome, and it still may fit sort of within the EDS family. I'm not going to go into those in particular because we could spend a lot of extra time. I wanted to go into some depth amongst the different types that there is also. So the most recent classification is quite old now, called the Villefranche criteria, and we'll do some comparison in a minute. The Villefranche criteria sort of sat down, these are the things that we consider the more unique or the diagnostic parts of these particular types. And it lists 6 major types. There was an older classification system that they basically revised or revamped. That is when we actually called them sort of by type 1 or type 2, and et cetera. And the Villefranche basically then gave them a name instead of a number. So this is somewhat the comparison. The formatting, unfortunately, got a little changed here. But you can see there's the Villefranche in 97 and the Berlin in 88. What you've yet to see is anything more recent than 97, and our understanding of a lot of these disorders has grown immensely. So there is an international effort underway to create a new classification system so that we can better describe what these are, to better characterize them. And so not just in a diagnosis, what do you need to make a diagnosis, but what does it all entail? What are all the issues that you can encounter, more or less sort of like what's the playbook for the clinician to how to take care of these patients? So it's one of those things we are working on. Unfortunately, it's a slow process, and especially when you consider it's a multinational process. We hope to have this finalized by mid to late next year. But as you can see from the older criteria, classic type was formerly called the gravis or the minus type, depending on 1 or 2. The hypermobile type sort of stayed the same. It was type 3. Vascular type actually has several different names to it, but it was type 4, and et cetera. This was a classification system that was published at one point in time, just a few years ago, that sort of highlighted the fact that our understanding of EDS and its minor types has started to increase, both getting better at describing what the features are. But the far right column, the gene, is what has gotten very important. Now that we've been able to characterize people and we have the technology to go after the genetic defects in sometimes great detail, we've been able to actually discover these genes and characterize that this particular feature fits with this particular genetic defect. So classic EDS is considered a defect of type 5 collagen. But there's classic like EDS with aneurysms. And it looks very similar to classic EDS, but it's due to type 1 collagen. So the collagens are common a lot, but the type 1 collagen we thought more as bone-related collagen, and the type 5 sort of other things. But it is one of the things that we're beginning to understand, that this collagen is involved in a number of different things, and therefore it can give us a difference in phenotypes or actual the physical presentations. So you can see type 1 collagen, COL1A1, COL1A2, involve several classic like EDS features, one with aneurysms, one with an osteogenesis imperfecta overlap, and OI basically is a brittle bone disease. That's the one that you can break with fairly minimal trauma. And there's a cardiac valvular disease. There's another player in here that I think we're beginning to understand, and it seems to be on the public chat a lot, the tensin X. The tensin X is another gene. It's not a collagen gene, but it does interact with the collagens. There are reports that if you're missing or have a genetic defect into one particular copy, remember most people have mom and sort of dad copies for these particular conditions. So a defect in one can cause features similar to somebody with hypermobile EDS. Defect in both copies can look more like classic EDS. That we feel represents a small percent of both those categories, but I think we do need much more understanding. Vascular EDS is by type 3, and we consider that's the only cause of that. But we've also learned that there's other conditions like Loeys-Dietz syndrome, which can look like vascular EDS, and then if we were to test for it, would be negative, and we would find out that it's actually another condition and not vascular EDS. Kyphoscoliosis, or type 6, we had several sort of look-alike syndromes that kind of look like type 6 but weren't proven to be type 6 or type 6A. And so we haven't sort of decided to label them all, B, C, D, E, etc. But that includes the muscle contractural, the spinal-cural, dysplastic, EDS with progressive kyphoscoliosis, and the brittle cornea syndrome. And a lot of people debate whether brittle cornea syndrome belongs into EDS or not. The one thing that's on here that's big question marks is something that's a common question for a lot of people. Okay, great, we found all these genetic defects for all these other particular conditions, but why is hypermobile still a question mark? And we frankly don't know. We know it seems to be inherited in a what we call autosomal dominant fashion, which means very likely one parent's affected and then it's passed down to the next generation. So we feel like it must be related to collagen. If it's not a collagen gene, it's a gene that interacts with collagen. But when we've done a lot of different studies, we haven't found a consistent change that we've been able to sort of pinpoint one gene or another. There's a lot of theories, but nothing has great sort of robustness of data to it, meaning that one, hypermobile is fairly common, so are we missing a fairly common thing by looking for what we think is a rare genetic defect and looking at it sort of the wrong way? Or is the hypermobile form actually several different genetic disorders that right now look very much similar, but once we get down to the genetic level, we may find that there's a hypermobile type B and type C and type D and et cetera. We hope that information will come, but that's right now, unfortunately, the future. So there is not a genetic test for the hypermobile form. There is a genetic test for the tensin XB form. There's some cautions about that particular testing. So it is not something I personally tend to rely on. So we're going to talk about, again, some of the more minor variants first, the kyphoscoliotic ones, and the other sort of type 6 lookalikes. As mentioned, is autosomal recessive. Its defect is PLOD. And this is an enzyme that actually modifies collagen at a very specific site. And so it looks like typical EDS. The skin is somewhat stretchy. It kind of bruises easily, it may tear easily, it may have the thin scars or atrophic scars, and you have generalized joint laxity. The main difference is they have severe hypotonia. They're sort of floppy babies. They have scoliosis. It may not be present at birth, but it can be. Most of them will present with scoliosis in the first year of life. And when you see scoliosis that early, it's pretty deforming, and a lot of times we would do surgical fixation for that. As you can see from the gentleman to the right, of how sort of deforming it is for his trunk. The other very unique thing about this is the sclera, which is the white part of the eye, tends to be thin. And your eye can undergo pressure. It can undergo pressure for a lot of different reasons. And it's one of those things, it's thinner and weaker, and with a little bit of pressure, one can actually rupture that. And so it is one thing that you can see in the kyphoscoliotic form of EDS. Minor clinical features include, again, the skin issues. The marfanoid habitus, that means just similar to Marfan or Marfan-like condition. And you can see the gentleman to the right looks really long-legged, long-armed, and a short trunk. It's always hard to appreciate, is the short trunk really because of the progressive scoliosis, or does this person really have a short trunk? But they look taller, thin, and disproportionately tall, and so they have what we call a marfanoid type of appearance. One of the main concerns for them is rupture of medium-sized arteries. So the aorta is the main artery that comes off the heart, and it sort of does a candy cane, comes off the heart, and then sort of descends down. And the branches from there we would consider more medium-sized arteries. And so those arteries become fairly friable, and they can rupture. So it's one of those things that is definitely life-threatening. When we look at the way we used to diagnose it, we used to diagnose it based on the byproducts related to collagen, the biochemical test. And it is fairly reliable. However, with the new genetic technology, it's one of those things that can be tested more directly by looking for the genetic defect, and that is the current preferred method. The muscular contractional EDS is also autosomal recessive. It's due to a different gene. It also goes by the name adducted thumb club foot syndrome. That sort of tells you some of the particular features. It looks a lot like the type 6 or type 6A with skin issues, kyphoscoliosis, the joint mobility, and sort of the low muscle tone. And it has eye features, but the eye features are somewhat more unique. Microcornea. So cornea is sort of the non-white part of the eye. If you see the picture, it almost looks like the young lady is looking up, that you can see only part of the color part of her eye, when in reality it's smaller. And so it appears like it's partially hidden or something, but she actually has smaller eyes. You may or may not appreciate from the video monitors, there's a little bit of blue tinge to her eyes. They tend to be significantly nearsighted. That puts them at risk for retinal detachment. That's when the back of the eye tends to sort of separate. They have some other particular unique facial characteristics. They can have joint contractures and some unusual fingers and hands, and various GI issues. And again, just going back, again, we know the genetic defect, so we can do direct genetic testing for this. The spinal dysplastic type also is autosomal recessive, has a genetic defect already sort of established. Again, hyperextensible thin skin, easy bruising, small joint mobility, looks like contractures, bluish sclera, wrinkled palms. So that very much looks like muscular contractural, but one of the main differences is they have spine and bone involvement. Cytospondylene is a sort of a flattening of the spine. Osteopenia is sort of a weakness or less density to the bone. And wide metaphysis, or a certain part of the ends of the bones that are wider than they should. So that looks a little bit more like a skeletal dysplasia or a bone problem, whereas some of these others look more just like a more typical connective tissue issue. Bradycornea is also autosomal recessive. It's due to at least 2 genes. There's probably a third one that's out there. They do have generalized joint hypermobility. They have very soft, unusual skin, easy bruising. They can have kyphoscoliosis, but it's not the most common one. Hearing loss is actually fairly typical. They have blue sclera, and they can have weakness of the cornea. That's called the keratoconus or keratoglobus, where the weakness sort of pushes out that part, and so it actually bulges more. And conus or globus just describes the shape of that. The ocular fragility is that thinness, just like the thinness of the white part of the eye that we see in the true type 6, this is of the cornea, and so that's the center part of the eye, and this can be thin and brittle and rupture also. So it's another eye problem, not quite the same part of the eye as type 6. It has some things in common, but stands fairly unique, and again, can be tested for. There's another type 6 lookalike EDS with progressive kyphoscoliosis, myopathy, and hearing loss. So it has a lot of the common elements that we sort of described, but due to another particular gene, FKB14, with progressive kyphoscoliosis, that causes the trunk and the chest to be sort of skewed and sometimes very thin, and that causes decreased lung volume, and therefore your lungs can't expand as much. But instead of being sort of tall, marfanoid, they're shorter. They can have hearing loss. They're also at risk of having this arterial dissection. The commonality for this is that the kyphoscoliosis does need to be managed, and sometimes fairly aggressively, by orthopedists. Physical therapy. Anybody with generalized joint mobility probably needs physical therapy. And a lot of times they may need orthotics to brace certain joints. The eye care is different for each different type, but the commonality through all of them is there tends to be much more eye features, so an ophthalmologist should be definitely involved in their care. Because there can be arterial involvement, we want to make sure we're aware of that, and echocardiogram is a good place to start, but it may not be the arteries around the heart. It could be further away, so one might consider doing imaging outside of just the heart, but also good blood pressure control, and a lot of times that's with a drug called a beta blocker, which lowers your blood pressure. The ocular Khaleja type is type 7A and 7B, and basically the collagen strains are put together and then they're kind of wound together. So think of a rope. And so these are strands that sort of wound together in order to give a little bit of tension but strength. And so what happens is the rope parts are kind of cut off. You can kind of consider them the frayed ends. And so when you cut those ends off, then you have sort of these nice, almost like bricks of this material that sort of come into a larger unit. Ocular Khaleja is where the cleavage of that is abnormal, and therefore you don't get, you leave sort of a frayed end. So they have some features in common with EDS. They tend to have much more severe joint hypermobility. You can see the child literally bending the fingers all the way back to the back of the hand. You can see the extreme knee hyperextension of the little baby in the picture as well. So they have skin features as well. They have low tone. So they have things similar to the type 6, but there is definitely a unique presentation for them. Dermatosparaxis is also, it's kind of like the converse disease, because this is the defect in the protein that cuts those frayed ends. So the first one The arthrochalasia type was basically the area of the frayed end. It basically was resistant to being cut. Whereas dermatitis praxis is the protein is defective and doesn't cut those. So the enzyme, a lot of the enzyme process takes, you need to knock the enzyme down to almost zero. That means knocking both copies, the mom and the dad copy, off. So dermatitis praxis is recessive, whereas arthrochalasia is dominant. Their features, even though it sounds like they should have very similar features, the features are still somewhat different. They can have joint mobility. Their skin is much more doughy and saggy. They can have blue sclera. They have other soft tissue stuff like umbilical hernia. They can have some mild skeletal features. So even though the process seems like it would be the same and they should have very similar conditions, they have overlapping but not quite the same. So let's move on to Vascular EDS. So Vascular EDS, basically, in the Villefranche criteria, has major diagnostic criteria and minor diagnostic criteria. It is also autosomal dominant due to type 3 collagen, or COL3A1. The skin is considered thin and to the point of almost translucency, so you can see the structures underneath, and that's the veins. It's hard. I've seen a lot of people who look kind of veiny, and it's very difficult to sort of really be sure what's too much. Obviously, people who are much thinner are more likely to look veiny versus somebody who's heavier set. So it is something that I would look for, but at the same time, it's not the most telltale sign. The skin isn't particularly stretchy. It does bruise, and it can be very extensive bruising. They have a facial appearance to them that's what I call textbook, but I'll show you there's a lot of exceptions to the textbook. The biggest concern with vascular EDS is life-threatening rupture of the arteries and sometimes other organs, and we'll talk in more detail. So this is the facial features. This is sort of a classic old slide, ends up a lot of medical textbooks and et cetera. The eyes are considered somewhat bulgy, have sort of thinner tissue around the eye. The nose is supposed to be narrow in the bridge or pinched-in nose, a thin lips, hollow cheeks. It's kind of a gaunt, somebody who's sort of almost starving or whatever type of appearance. You can see some of the commonality. I can't always convince myself that all four of those people have all of those features, and that's not unusual. While these are typical things, there's hardly any person who has all of them that fits this. One of the things that's difficult with this is that the features can change over time, and sure, you can realize how facial features do change over time. But there are some times where it was never present in their family's life. And I have, family documentation of people, two sisters, one who Facebooks that way and one who doesn't, and sure enough, they both had it. And the one who looked more normal, her child had much more characteristic facial appearance, whereas the other one who had the characteristic facial appearance, her child looked more normal. I don't have a good explanation for it, but I can tell you it's not, if it's there, it's helpful. If it's not there, it is not something that particularly is hurtful to the diagnosis because you're looking for other things. But at the same time, if they don't have some of these features, then how do we suspect the diagnosis? The unfortunate part is that most of the time when these patients show up at my office or another geneticist's office, probably close to half the time it is because somebody has already had a death in the family and they suspected vascular EDS, and so the family member is there. So a lot of times it takes a tragic event before somebody suspects it. And that goes to the actual clinical presentation. So a number of people live with nobody suspecting it for, a few decades, and then sometimes all of a sudden something catastrophic happens. And you can see from the little pie chart, the first complication, the organ is the 5%. That's where an organ ruptured. That can be the uterus. It can be certain other things. 46% with an arterial rupture, and 19% with gastrointestinal. Now, the gastrointestinal is an organ too, so it's a little bit, it's considered a little bit different here, but it is a very common thing where the bowel will actually rupture. That itself is somewhat survivable. The problem is when they rupture the bowel contains a lot of bacteria. You've now created a super infection, and that sometimes is the actual cause of death. Like a lot of other things, there's a lot of other minor features. The hands appeared somewhat aged. The skin tends to be thinner. They do tend to have some hypermobility of small joints, but I don't really honestly think that is very well characterized of who has what joints that's hypermobile. Is it always generalized? Is it just the hands, et cetera? And unfortunately, in most people's experience, I as a professional may only have 10 patients in my practice, even though I see literally thousands of people with EDS, and that's not unusual from center to center of having only a handful of patients. And so sometimes it's hard to get the information to feel like you understand a pattern well enough because you've seen it over and over and over. But they can have tendon or muscle rupture. They can have a club foot. They have arterial venous fistula. That is where the artery in the vein makes an abnormal connection. That is sometimes a referral point. Pneumothorax is when there is literally a hole that sort of in the surface of the lung that causes the lung to deflate. That is something we think a lot more commonly with like Marfan syndrome, but it can be seen in vascular EDS. The other features, develop dysplasia of the hip. That's where the hips are kind of loose, and sometimes we have to put them in a special device to sort of make sure their hips develop appropriately. Keratoconus we talked about. And they can have a number of actually gum and oral manifestations as well that I think, again, are underappreciated. The overall survival, we talked about sort of the first complication, but the average age is around 30, with the survival around 51 years of age. But the thing is, we're learning, again, more about genetics. We sort of lumped everybody together, but as we started learning more about the genetics, we were able to sort of split people out. And that's what the graph is sort of showing. It's hard to sort of talk about mutation type. If one compares sort of the green, blue, and red as one group versus the purple, one is where the collagen is made incorrectly, and it basically spoils the soup. Whereas the purple is more of it's missing, and that means an ingredient, a key ingredient, is not in the recipe, and so it makes changes, but the changes are somewhat different. And so what we typically have sort of thought of as a geneticist or as other people, what we've thought about as vascular EDS is more of the red, green, and blue, and what has come to light is that there are plenty of people who are missing that gene who may present much later in life and may never present with any problems their entire life and go unrecognized, but it's not until somebody in the family has a catastrophic event that the family gets then identified with a type 3 mutation. One of the largest concerns is around pregnancy. Pregnancy obviously causes drastic changes in blood pressure, so there's risk of arterial rupture. But the other interesting thing is the uterine rupture. The uterus is considered a hollow organ. Obviously, it has to have space for the baby. It is very rich in blood supply, and what is the connective tissue is sort of the scaffolding. So if the scaffolding sort of collapses, like you might have seen in different news programs where, you know, a floor or something else because the scaffolding sort of falls apart, that's sort of what happens here. But under pressure, so imagine the pressure of trying to go through labor and deliver a child, and the uterus then just ruptures. It literally sort of blows itself apart. It's a very enriched, engorged area of blood, and it's something that can lead to death. Other vascular features, it includes medium and large size arteries. So a lot of times we'll see not only the aorta, but we'll see the vessels coming off the aorta, such as the mesenteric, the splenic, the renal, to the point that, you know, a third of the time they're in the chest, a third of the time they're in the abdomen, and the other third of the time they're spread out between the limbs and the head and neck. So we really don't know where anything will happen. It's not Marfan syndrome. We really worry about the beginning part of the aorta or the aortic root, whereas in vascular EDS, it can be anything, anywhere, and at any time. And so it's one of those things that is important to recognize, but there's not a lot of features that really allow you to be able to recognize this very easily, and unfortunately, a lot of these people go unrecognized. When we get a diagnosis, the recommendations are not by vigorous research or anything else. We had talked about a long time ago that echo and echo only. We were concerned about putting contrast in people with vascular EDS, that if the contrast, if they would have a vascular rupture while they had contrast in, then the contrast could cause significant problems. And so for a long time, there was the idea that, no, we shouldn't be looking at these individuals. The other part of that is the vessels, when they try to put them together, so if there was an area of weakness and somebody would have put a graft in or some other structure, the tissue would sort of fall apart. And so even if you identify the area, going in and trying to correct that had a very high risk. And so it was almost like, well, we prefer not to know. And honestly, I gave my patients that choice. Do you want to know or not? And some would choose one way or the other. Anymore, because we have more options for these patients, we do feel like we should be monitoring them. We should be looking to see if there is an artery that seems to be enlarged, so that we know that that's a particular risk or anything else. That does not mean that we see everything and we capture everything, but that's probably the best that we could do at this particular time. So what is new? I've sort of already alluded to these points. What's in the textbooks has now changed. There was one particular type of vascular EDS, and we find this whole group of other people who are just missing the protein and have different features, and sometimes on the lesser side. There was a French study with a drug called celiprolol, which is a beta blocker, which in their hands reduced the number of vascular events in patients with vascular EDS. There were several issues with the study. One, it was stopped prematurely, and two, not everybody was identified with vascular EDS. They were suspected to have vascular EDS. And so there was a lot of uncomfortableness of going forward with that as a standard treatment. There was a call to actually introduce this into a wider clinical spectrum so that we could study this further, but efforts have not really come to fruition. There are a couple of mouse models you all may be aware of. People have been looking at what happens in those mouse models to see if they can understand the vascular events in humans. One used doxycycline, which is actually an antibiotic. how that antibiotic works, think of a bacteria that wants to get inside your tissues. Well, your connective tissue tends to be the fence. It's got to get through the fence first. And so it produces, it sort of induces the breaking down of that fence. And doxycycline prevents that. So it actually prevents the bacteria from sort of migrating out. And the similar process of breaking down that fence or the connective tissue is what we propose is happening in vascular EDS. So doxycycline may work. There's still, mouse model is not a human, and therefore we still need more. But, every good news is exciting news, and we just need to keep looking. Similarly, TGF-beta is transforming growth factor beta. It is what we call an inflammatory marker. And so what happens under inflammation, this gets produced, and it causes all different kinds of things, including breaking down of the connective tissue. In Marfan syndrome, it is one of the more primary candidates, and we have found a drug called losartan, which is another high blood pressure medicine, actually blocks that action. And so it works very good in Marfan syndrome to the point where it is now recommended as standard therapy. In vascular EDS, there is the role of TGF-beta in vascular EDS is not well understood. In mouse models, they have looked to see if the TGF-beta is increased. Some of the evidence suggests it is. So potentially targeting TGF-beta would be the way to sort of go about this. So there are some who are considering treating vascular EDS patients with losartan. But again, information is a little premature, but it's probably not a harmful regimen. The last I find somewhat more exciting is the endovascular treatment. And that is because the tissue was very friable or loose, one needed to be careful of trying to sew through that. Well, with the right technique, you can actually go through the inside of the vessel and place a device that is sort of an inner wall. And then that way there'd be less stress on the outer wall, and that was something that just has evolved over time to the point that we've been able to use it in certain situations, and there have been several case reports that suggest that this is a viable alternative. So that would be a reason to go look for arterial dilation and catch them before they rupture and do something about them. The unfortunate circumstance is this is not an uncommon technique, but definitely less common in the vascular EDS. So it may take a more experienced hand or sometimes a more bold person to actually do it, and identifying those people so that they're available wherever vascular EDS patients has been an issue. Classic EDS. So classic EDS is the people who have very stretchy skin, tend to. They have the widened or thinned out scars, joint immobility, and a positive family history. Those are the four major criteria. And if we consider patients with with three of the four criteria, then 90% will have a defect of the type 5 collagen. So that still leaves 10% who look like this that we don't have a good answer for, but those are people that we can feel fairly comfortable. And matter of fact, that means our genetic test is very good, but I can also tell you that if those are the criteria, I can almost make a clinical diagnosis and probably be greater than 90% assured that that's classic EDS and don't necessarily have to have the testing, but the testing is available. Minor criteria: smooth, velvety skin. They can have other skin features. Complications of joint mobility was sort of discussed before, easy bruising, and then sort of weak tissue, the hernias, the rectal prolapse, etc. There are certain cases that have been remarked as having arterial aneurysms and rupture. those are case reports, and it's difficult to know what is the real risk in those individuals. And I'll explain why in a second, why I'm a little concerned that they may not be classic EDS. It may be classic EDS with arterial aneurysms. This is another one. The people have skin laxity, atrophic scarring, easy bruising, joint mobility. They may have a positive family history. But the more unique thing is, while they look like classic EDS, they can have very low bone mass or osteoporosis to the point where they can have low trauma or bone fractures, stepping off a curb, breaking a leg, doing those kinds of things. But the other thing is, unfortunately, the trifecta and the evil trifecta, in that not only do they have classic EDS features, not only do they have OI-type features, but they also have a propensity to rupture arteries. And so they also look like vascular EDS. But this is due to type 1 collagen, that bone collagen. So things, this is where, and I'm not going to touch this hot topic more than say there are, implications that people with EDS have, bone fragility, and et cetera. There are a few types that do have bone fragility. You'll see these types are related to type 1 collagen, just like in osteogenesis imperfecta. So it should be reasonable in any of those cases where there is a question of bone fragility to test type 1 collagen and see if they have one of these unusual forms of EDS. The cardiovalvular is another form of unusual EDS. It is due to type 1 collagen, but it's where the type 1 collagen is missing. And this is a particular form of the type 1 collagen called COL1A2. It's sort of the minor component. And so that leaves the major component in there. It does change how things are. They can have skin involvement, not as dramatic, hypermobility, low bone mass, low tone, but their more pressing feature is they can have heart valve issues. There is truly an EDS-OI overlap, and this is due, again, to type 1 collagen. It's very specific changes in type 1 collagen that cause much more of skin laxity and joint mobility, and also the bone fragility. But even if you go look at patients with osteogenesis imperfecta due to type 1 collagen, one of their major features is joint hypermobility. And a lot of times I'm treating those individuals for joint mobility as well. Tenacin X is, if it's truly deficient or both copies deficient, this is where it looks like classic EDS, but the main distinguishing feature is that the atrophic scarring is not present. The hypermobile form. So this is the Villefranche criteria, the older one, autosomal dominant. There are a few case reports. There was one single case report of type 3 collagen that sort of caused this. We think that was probably a variant or a benign finding. And then, of course, there are those with Tenacin X. This probably represents under 3% of the hypermobile group. The major features are generalized joint hypermobility, which I do think, despite the failings of the Beighton score, can be one of the things fairly easily tested and somewhat agreed upon. I can sort of teach my residents and et cetera to sort of do this exam, and they can come back and say, yes, this person is somewhat lax jointed. The skin is considered soft or velvety, and that's more like the classic EDS, or normal. And I always roll my eyes with this. You can't see it because we're not doing video here. But the thing is, that would probably include 98% of the population. So it is not a criteria that we can use. Even if we use soft or velvety, some of the data in my own experience with my mentor was that we disagreed a lot of what was soft skin, to the point that I was groping people around just to feel what their skin was like compared to the patient. So it's one of those things where it is not a very reliable indicator. So if that drops out, all we have is generalized joint mobility, and then some minor criteria is you could have a positive family history, you could have joint subluxations and dislocations, you could have pain, You could have easy bruising. So these are things that are not the most robust things to sort of say that you can be more objective about. So that's the reason why the hypermobile form is a bit of the black sheep of the EDS. Not only is it a clinical diagnosis because we don't have a genetic test, we are really relying on fairly scant objective material that I can sort of make sure that the next person who sees this patient is in agreement with this particular diagnosis. And that's the reason why we really need to work on this. Sometimes I get asked, is this a real thing? Yes, it's a real disease. It's a real syndrome. But it does take a little bit of an art to actually diagnose this and recognize it. But it all starts mostly with the joint hypermobility recognized as a physical feature, and then taking the history, both the family history and their own personal medical history, what's happening with their joints, do they have pain, do they have pain that is explained by joint hypermobility, and you can start putting the pieces together. But as you are probably very much aware of, these particular, this is a fairly shallow description of this particular type. And so we have broadened that very significantly of what we feel like encompasses many of the patients with hypermobile type. Now, the difficulty is that there was the hypermobility syndrome, and its official name is benign joint hypermobility syndrome. It was called benign because it was not life-threatening. So it was distinguished from Marfan syndrome just because Marfan syndrome could kill you. And so in '67, when that was coined, that was the intention. Today, we think benign as it doesn't cause a problem, and so obviously there's always a misunderstanding. If I go in front of a bunch of medical students and say this is a benign condition, or just even throw out the benign part, they're going to shut off their brain for a second and then tune back in a few minutes later. So most people don't really know a lot about this. It is a more commonly referred to joint hypermobility syndrome or just the hypermobility syndrome. The main criteria is somewhat similar to the hypermobile form of EDS in that you need joint hypermobility. The cutoff here is a little different. In EDS it's 5, here it's 4. Joint pain was a major criteria. So they're asking for the people who have joint mobility, but they have at least an issue related to that, and that is sort of joint pain. There's a bunch of other minor criteria which look very similar. You can have back problems of spondylolysis, spondylolisthesis, dislocations or subluxation. You can have the soft tissue rheumatism. You can have a bunch of other sort of connective tissue stuff. They did a much better job of describing their syndrome than the Villafranche did describing hypermobility EDS. The hypermobility syndrome was described by adult rheumatologists looking at adults who had a history of this, who were having problems. The Villafranche criteria was looking more from a pediatric perspective of the people who were hypermobile. And so what the belief was is those people transitioned into the adult form. That's where I started recognizing some of this stuff, in part because if we look at joint hypermobility syndrome across the population, very common amongst different types. I'm sorry for the formatting here, it sort of changed. And you can't see this graph. The intention wasn't for you to necessarily see the graph. But this is our joint hypermobility syndrome. And the labels are various different systems where there's a problem. The black bar is joint hypermobility syndrome, the white bar is the controls. And if you took this and I scratch out joint hypermobility syndrome and put EDS, we'd all probably believe the same data set. And so what was happening is we were describing the same symptoms in two different groups. And so they started looking very similar. And there's a lot of history behind this that Professor Graham does a great job explaining. But ultimately it came down to, we suspected that they were probably one and the same in that what we called hypermobile EDS was a pediatric perspective, and what we called joint hypermobility syndrome was the adult perspective. There were some data that sort of fill in some of that, but one of the studies that just was published was a very nice data to looking at, I believe, 26 families in Italy that looked at multi-generations and basically showed that there was a good correlation between what we label joint hypermobility syndrome and what we label hypermobile EDS using the current criteria that they look like the exact same disorder. And so there is the professional opinion by, I would say, the majority, but not the huge majority, that they're probably one and the same. But you're going to find a lot of people who are still staunchly against that they are two separate entities. But for the purpose of the talk, I will consider them the same. So we're going to go through this in time to sort of do everything here. But whether you plug in joint hypermobility syndrome or you plug in hypermobile EDS, the puzzle pieces are getting put in. So we're seeing things like fibromyalgia, migraine headaches, chronic pain, dysautonomia, sleep issues, fatigue, panic disorders or anxiety, GI symptoms, mast cell. All these can sort of go around, and you can put, whatever name, because you can find the literature to support joint mobility syndrome as the center part, hypermobile EDS as the center part. And even now, you can find other chronic pain disorders to sit there in the middle, fibromyalgia to sit there in the middle, and have similar kinds of things. And in some ways, this is an exciting time because what we're seeing is a better understanding of chronic pain syndromes, and that includes EDS, and I think in some places we have led the way of explaining more stuff related to chronic pain and how it's all connected as compared to some others. So let's talk about pain, because pain is either number 1 or 2 on most people's lists when they have problems. The pain is not the same pain. It's not the same pain between individuals. It might not be the same pain from one minute to the next. It can be localized. It can be generalized. It can be muscle pain. It can be acute or episodic, which means it occurs when I do something, or it can be always there. It can be both. What we call acute on chronic, where you have chronic pain and then there are certain things you do that make it worse. It often is activity related. You do things and it does make it worse. It can interfere with sleep. It might be really partially with rest, but I can tell you there's a good number of people who would argue absolutely not, but I think that's on an individual basis more than anything else. There is typically no morning joint stiffness, and I'll put a big asterisk next to that simply because if the muscles get really tight and et cetera, you can have joint stiffness. The thing here is that it's not supposed to look like rheumatoid arthritis or one of the other types of arthritic conditions where you have early morning stiffness. Pain starts to interfere with a lot of things. It interferes what you might do physically. It may interfere what you do socially. You may figure, I can't go out with my friends tonight because I'm not too sure I'll be in pain or not. I don't know how well I'll move, so I don't want to go out clubbing or whatever else. It causes people to rely on braces or splints or do other things, and sometimes they're improperly used and cause other problems. If you stop doing things because they hurt, then your muscles can start actually losing their condition, losing their toning, which can cause further worsening of the joint issues. So that's muscle deconditioning. And a lot of times, because our muscles slip and move and et cetera, we start to adopt improper mechanics. We start to do things the way we know our body can, but that may not be the way that it's actually supposed to be done and can cause us damage. So that's an important point that we always need to address. This was a study that we did in clinic back in Cincinnati. We looked at what's called a brief pain inventory, which has two components, the pain severity score and the pain interference score. The severity score is just like how bad is it, and the interference is does it stop you from sleeping? Does it stop you from going out with your friends? Does it interfere with work, school, those kinds of things? And you can see EDS compared to controls clearly different between the actual two. one of the things to sort of I'll fold back in here is pain interfering with sleep. And sleep is a very important thread through a lot of this. Chronic pain, this was from the Dutch EDS group where they were given. So a lot of people, who step up and say, so what, you're hypermobile, big deal. I know plenty of people are like that. Whether or not EDS, hypermobile EDS is a subset for some reason, why do some people have problems and why others don't? Sometimes I can drill down, a lot of times I can tell you some of the differences. And so it's one of those things where, you may have a difference because somebody was always a high school athlete, keeping themselves in good condition, and they go to college and they don't do their athletics or physical activity, and all of a sudden here they're 19, 20 and have incredible pain. That can be one of the main differences. But injuries, hospitalization, sicknesses can put people so far behind in their muscle conditioning, et cetera, to actually cause problems. So we can see like one sister have a problem and one not. Oftentimes I can drill down to find out why the reason. For a lot of people, 92% chronic pain, always there as a chronic, it was very disabling. It was disabling in the daily functioning, disabling in school, and disabling at work. And compared to other forms of EDS, joint immobility syndrome, or the hypermobile form of EDS, they were reporting higher pain scores than the other forms. This is actually a higher prevalence of people. So these are people with fibromyalgia, and then looking in those groups, whether you're sort of the light blue or the darker blue, is how many people met criteria for EDS or joint immobility syndrome. And you can see, and I quote, sort of on average, about 45% of the people with fibromyalgia actually have joint immobility syndrome. And fibromyalgia was probably secondary because joint immobility syndrome was probably there in childhood, and as you started having pain and the things were going wrong, then you develop sort of more typical symptoms of fibromyalgia. And you may not have recognized that fibromyalgia may be the primary diagnosis, the first diagnosis, but only in retrospect do you find out the other things. The chronic pain tends to be a little bit of everywhere. Everybody's a little bit different. I give my patients this little body to sort of fill out. Sometimes it's shaded all over the place. A lot of times it's fairly joint specific, but head, neck, shoulders, back, very common to always be sort of shaded in. The pelvic area, including the hips and just chronic pelvic pain, limbs down to thigh muscle pain, to knees, foot and ankle, fairly common. Hands and wrist, also fairly common. So there are some spaces, and this is musculoskeletal pain that was focused on. Obviously, there's a lot of individuals with chronic abdominal pain, too, that we would have to shade those in. So the problem is, and the reason why I think people are beginning to understand chronic pain a little bit better is that if we look at the brief pain inventory, the pain interference, and I sort of mentioned this before, so pain can interfere with sleep. And you can use different criteria. This is where we use different called instruments to actually measure that. Decreased sleep increases fatigue, decreases quality of life. And you can measure this. But decreased sleep increases the perception of pain, and then that cycle starts, and it's a downward spiral. Increased perception of pain, decreased sleep, more fatigue, quality of life, goes round and round. But don't forget, pain is not necessarily the primary thing, because things like depression, and it may not be full depression, it may be depressed. If you're used to doing things and now you can't, it's common to have a depressed mood about it. That may interfere with sleep, it may cause some anxiety, and et cetera. Then you're on medications. Medications can interfere with sleep, they can increase the fatigue, and et cetera. So there's a lot of factors that do come in here and interplay through all of this that sometimes is very hard to sort of tease out. And while I feel like, I'm going through a little bit of a playbook to help people, it definitely is not a one-size-fits-all. And so sometimes you try this and, this one's a little bit different because this particular aspect is worse than the other. And so it is a bit of an art form, but the thing is, you and the provider both have to stick with it, not only with the plan, but with the idea that this is an evolving process, that we work on one issue, we're working on the second issue, we're working on the third issue, and et cetera. But careful not to add the medication effects on top of this. Pain management EDS, therefore, to me is somewhat straightforward. We have to watch what we do. So sports, activity, work, that's ergonomics, that's pacing, just paying attention to those. You have to have the physical therapy. The muscle tone has to be there. It has to help with the joints. But a lot of people have the muscles, one's that dominating, one's that not, and you got to sort of move them. And the way you move them is sometimes stretching the dominant shorter muscles and using muscles that gave up because the joint's too loose, I can't control it. So that's called neuromuscular retraining. The problem is most patients get into physical therapy and they look relatively, quote, normal, and therefore we're going to start you on strength training and aerobics. And if you have pain, those are good options. If you have joint mobility with pain, those are not necessarily good options. So we do have to look at that a little bit differently, which sometimes is why people fail in physical therapy, not because of the patient, it's because of the approach. You may need different orthotics. I like NSAIDs, the anti-inflammatories, lead ibuprofen, not necessarily for pain management, but there is, when people stress their joints, there is some inflammation. And so it is one of those things, it's a low-level inflammation. The NSAIDs can help a little bit, but they're not going to take anybody's pain level of 7 and drop it down to a 3. So I like a little bit of anti-inflammatory there, but not to the point where I'm causing, stomach upset or whatever else. Medications for nerve pain are sometimes antidepressants. Most of that is because once somebody is in the chronicity of their pain, then their nerves tend to get sort of hyper-agitated, and therefore what you need is something to help calm those nerves. So that's what you use. Analgesics can take care of different kinds of pain, a lot of times more musculoskeletal pain. So it's one of those things that you have to approach sometimes like the muscle pain, the joint pain, and the nerve pain all differently, and you have to approach some of that as chronic pain and some of that as acute pain. So it's not a simple formula, but again, if both parties sort of stick to it, I think a lot of patients can get through and have a significant difference with some modest pain management intervention. Psychiatry and psychology, I can't emphasize enough, and it's not because you're depressed, you're anxious, or whatever else. It is mostly because you are depressed and anxious. It's always nice to have someone to talk to. That's just feeling good about yourself. It's not saying the stuff's in your head, and that's the reason why you're in pain. The other thing is we all need sometimes just a joker in the deck that basically says how I need to deal with my pain. And all the medications don't take the pain away. And it's not saying that any kind of mental tricks or cognitive behavioral therapy or biofeedback take the pain away. It just empowers us a little bit better to actually cope with the pain and mostly focus on what we need to do. If you're a parent, it's taking care of the kids or doing your job or doing something else. So there's an aspect of that of I'm going to shelve my pain away. It's not saying it's not there. It's just I got other things to do, and the pain seems quieter. So that is a nice mental barrier that you can create through psychological help. and et cetera. So I do recommend it, and I think people should take better advantage of it. Headaches. Headaches are very common in joint hypermobility syndrome and EDS. Migraine is the most common, but headaches are multiple types. And so you can have a headache because your jaw is a problem. You can have a headache because you have myofascial muscle pain. You can have sinus disease. You can have headaches due to neck problems. You can have high-pressure headaches. This is where the Chiari-like symptoms are coming in with the base of the skull, this cranial-cervical junction, being blocked and causing the spinal fluid not to actually go down the spine like it's supposed to, builds up in the head, causing, quote, high-pressure headaches. Then there are low-pressure headaches. And dural ectasia is one of those things that you can see in connective tissue disorders. But I think in EDS what we see more is leaks. And sometimes they're spontaneous leaks, but a lot of times it's, I have headaches, I have headaches, I have headaches. Somebody does a spinal tap or does some procedure, and we all know people with EDS have poor healing. Well, that dura doesn't heal either, and so it continues to leak that, and then the fluid actually drains, and you start having low-pressure headaches, and those things can be very problematic too. There are multiple reports with headaches as far as occurring, and you can see anywhere from 30% to 70%. This was an interesting population here. Most of you are familiar with Dr. Blair Grubb, fairly well known in the EDS community. Basically, they looked at people with POTS mobility syndrome, and migraine was much more common in the people with joint mobility and POTS than those with just joint mobility alone. That kind of pointed a finger that some of these headaches may be more related to dysautonomia. But it is probably only one type, because again, a lot of people actually have multiple types. This is another one. Again, here's 18 EDS patients, 4 with migraine with aura. That's the people who see sort of these flashes of lights and et cetera. 4 without the aura, 4 with tension headaches. That's more the muscle kind of stuff. 4 with combination, 2 post-traumatic headaches. So yes, a lot of people had headaches, but they had different kinds. And so sometimes, again, a one size doesn't fit all. I think the dysautonomia headaches are fairly common. I think muscle tension headaches are also very common, but so is TMJ. So those are things you need to sort of track down. This was a study that we did that sort of looked at joint mobility patients. We got 75%, similar to other studies, looking about how common it was, how frequent it was, which was more frequent than the controls, and that it seemed to actually interfere with life at a much greater proportion than somebody with migraines and no joint mobility syndrome. This was another interesting article. It was a very small number of people. It was 12. Basically, he looked at a type of headache called a daily persistent headache, where it sort of never waxed or waned. And he described that, gosh, you know, I have 12 of these people with this type of headaches, and 11 had cervical spine hypermobility. 10 of those, or 10 and 11, had generalized joint hypermobility. So here was a new type of headache related to joint hypermobility. So we know neck pain, and neck pain is a very common feature, but neck pain predisposes to some of these headaches. The neck can feel stiff or tight. You can get pain to the back of the skull here. You can feel pain sort of to either side. You can feel an ice pick. So there's a number of different things that sort of can happen, but the skull and the spine meet. Every bone-to-bone connection is considered a joint. So where the skull meets the spine is another joint, and most joints are controlled by ligaments, and there are very strong ligaments in the cranial-cervical junction. So, you know, there can be problems that are in that area, that joint, which can lead to the same types of stress that you see in tendonitis and bursitis, et cetera, with other joints, you can see in the neck as well. The other thing is, because of the abnormal loading of the spine and et cetera, I have seen many 20-year-olds with degenerative disc disease. And, you know, it's one of those things where they'll see a little bit of it in some people, but it's a remarkable finding in a lot So it's one of those things that can cause significant amount of pain. This is a cervical suboccipital This is the cervical suboccipital headache arising again from the pain in the neck. It can radiate to the area. It can radiate the different nerves to the different areas of the back of the skull. So it's one of those things that sort of headache in the back of the head can be more neck pain than anything else. And this is where the ice pick headache comes in, and that to me is more classic sign of the cervical junction. This was 2 studies that said, about 4% have cervical genetic headache, but it's definitely less frequent than the muscle tension type. The muscle tenseness and et cetera from the neck pain cause reduced motion of the neck. And so it has some particular uniqueness to the features. It is not a common type of headache and is constantly overlooked by even headache specialists. But it's one of those things I think we need to constantly think about. In our study, when we looked at head and neck, basically we tried to sort of like, where's your pain? 30% had facial pain, 20% had posterior-cranial, that's sort of the back of the neck, 50% had sort of their neck area, and then at least almost 70% or 2/3 had basically pain in one of these 3 sites. Our approach was physical therapy, and physical therapy is a common design for a lot of particular things. If there is improvement, you continue. If there's no improvement, you do consider imaging the spine, appropriate consultation, etc. You can go for diagnostic and therapeutic nerve blocks. That's where a pain interventionist will come in, and you can do things like epidural steroids and the decompression. So a lot of people are stuck somewhere in this loop when it comes to evaluation of their pain, and it's difficult to navigate, and I wish I had better guidance for you. The overall treatment of neck pain, this was sort of a little bit of our outcome. This was with physical therapy. Those that were improved, mild relief, but symptoms continued no relief. So this was the, gosh, my neck feels a lot better. Basically, pain meds and physical therapy. Mild relief had some physical therapy, pain meds. But it's one of those things where they don't have to be exclusive, and so it is not uncommon that people use a combination of these particular 3. Anytime that we see the pain back there, we still need to look at the physical therapy. We need to assess anything around the neck. That includes the jaw joint. We need to see how the head is positioned, where's the shoulders, what's going on with the shoulders. So sometimes TMJ specialist may be the person that makes the most dent in their pain, or pain management will, or a spinal surgeon if it's truly more of an instability issue. The problem is we still can struggle to continue to struggle with what is the evaluation to assess the neck. And so it is commonly recognized that we should probably at least do x-rays. The picture here shows a very straight spine that is abnormal. That shows muscle tension. But all it says is you have neck pain. That's what you told us to begin with. It doesn't really show much of anything else. There are certain maneuvers that we can do as far as movements or particular angles of shots, can look to see if the bones are shifting, but if you're guarding because you have neck pain, sometimes the bones don't shift as much because your muscles are holding them in place. So people go to MRIs and take a look at these things. Again, this one has a very straight neck. We look at the many different things here. Dr. Henderson has probably talked to this group in the past, or other neurosurgeons, looking at like angles of the midbrain here down to the spinal cord, how much room is up here at the cranial-cervical junction, and et cetera. And I won't go into a lot of details, but there's a lot of things to look at. Unfortunately, not a lot of neurosurgeons view this the same. So we can look at the same case, the same x-rays, and come up with many different opinions of what it is and what to do about it. Some people will do what's called a rotatory CT. What we're looking for is see if the bones sort of slip too much. This is, again, one joint. Is this slipping too much in comparison to the other? And unfortunately, the data as far as what is normal isn't always isn't the most robust data, as in we don't have a lot of good data on this, and so it's still a little bit iffy and controversial. The treatment, again, you can go to the various surgical options. This comes from a couple of the different surgeons. Long-lasting severe is not responsive. So basically they're saying that, if you don't respond to the conservative therapy, surgical decisions, surgical options should be on there. And they both say this. And so you can find this opinion from a lot of spine surgeons that say, to me, it's not any different than any other joint. If you do the physical therapy, the orthotics, and everything else, and that joint is still unstable, you should consider surgical options. And so that's what we're sort of talking about. TMJ, the jaw joint, it can be hypermobile. It can cause clicking, difficulty chewing, pain, and etc. Sometimes the pain is not the jaw joint, which is right here. It's actually the muscle controlling the jaw joint. So sometimes the pain is at the temples, and people will complain of a headache there instead. I'm going to skip over this because this is too hard to read. This is about TMJ, or TMD is its more current term. It's a very common type of headache, again, underappreciated by those who just treat headaches. It can cause episodic or chronic migraines, and so it's one of those things, again, when I'm taking a headache history, I'm asking a lot about the jaw and et cetera. This was our study where we looked at it. 74% of our patients had a positive screening questionnaire. That doesn't mean they have the diagnosis. That means they had symptoms of this to the point that they should be evaluated by a TMJ specialist. Pelvic floor issues, just to sort of go over somewhat quickly, there are many structures in the pelvic floor, but remember, there are bones, there are ligaments, there are muscles, there are fascia. Fascia is another connective tissue. It's kind of like ligaments, but it's more like a hammock type of a sheath and more of a cord-like, which ligaments tend to be. So when they're weak, that's two structures in there that can cause weakness. They can cause the bladder to sort of pooch out. They can cause stress urinary incontinence. That's when people cough or sneeze and kind of dribble. The rectocele is when the rectum sort of pooches out. So there's a number of things that just a weak pelvic floor can sort of do. It's a social problem. It can be very painful as well. So this is a slide from another person just talking on pelvic floor issues, not talking about connective tissue. And I found this slide very interesting. It talks about being erect causes, issues on your tissues, and you can have. So the more you're upright, the more stress you put on. The heavier you are, the more stress you put on. The more children you've had, the estrogen level, how old you are, like how many years you put on your pelvis, and any intrinsic collagen abnormalities. I will tell you the division between a lot of specialists would be I treat EDS, but I don't necessarily know what a pelvic floor person would look at this and come to find out that we really are concerned about the same thing, but we never really talk to one another. So it's one of those things, again, as we're throwing stuff out there, we're reaching out to other disciplines and going, oh my God, this sounds like all my patients with pelvic floor issues. Guess what? They could have an intrinsic collagen abnormality. The conservative treatments, again, these are things from that slide. Basically, pelvic floor exercises, regular physical activity, weight loss if it's needed, avoiding some of the things that put the stress on there. There is reconstructive pelvic surgery. I'm sure you've seen many lawyer advertisements about mesh and those kinds of things. The mesh is definitely safer in current practice than it was in the past, but mesh is basically substitute for your connective tissue. And so it's one of those things that you can use to sort of put things in there. If things are weakened or torn, then definitely you want to reattach things. Fatigue. I have no freaking idea. It's chronic fatigue syndrome. So chronic fatigue syndrome was thrown out a lot for people who just complained that they felt tired and the doctor couldn't find what the problem was. There is a real diagnosis, but that's what this makes light of. I can't figure it out, so I'll just call it something, and I'll call it chronic fatigue syndrome. So in EDS, Peter Rowe is also well known to the EDS community. He was one of the first ones that talked about chronic fatigue in EDS, but also about orthostatic intolerance, sort of that dysautonomia stuff. Many people with chronic fatigue syndrome also fulfilled chronic criteria for joint hypermobility syndrome. So there was an enrichment of joint hypermobility in chronic fatigue. Sleep, very important. These are some of the quotes. I sleep with several pillows. I call this pillow cocooning, trying to shove everything else to support your body. Constant movement, rolling, kicking, thrashing, wake up multiple times. Very common complaints among the patients. When we look at sleep needs, teens, 8 to 10 hours, adults, 7 to 9 hours. There are many of my adults who are really getting closer to 3 or 4 hours of actual sleep in the night, and even if they're getting 7 to 9, it's still not refreshing. This was a study of my patients. On average, they spent 8 hours in bed. They slept 6 of those 8 hours. The benefits of sleep are wide-ranging. It helps with cognition and memories. So if you learn something and you get nice, restful sleep, chances are you'll retain that better. It will help with concentration. We all know people who are very moody if they're tired, kids especially. It helps the body sort of repair, and that helps the body stay healthy and fight off infections. And there is a hormonal control that happens with sleep cycles. Growth hormone is a very positive hormone, not for just growth, but metabolism and sugar processing, et cetera, so is cortisol. All those are regulated. So I do get a lot of patients who are like, oh, well, your cortisol is abnormal, and therefore you need cortisol. And most of the time, it's not the cortisol you need, it's the fact that you need better sleep. And so if you're not sleeping, your cortisol level, which can change during sleep and in the AM hours, if you're a person who doesn't sleep, your cortisol level is abnormal. Whether it's a chicken or the egg, not really sure, but I'm fairly confident cortisol is not the problem with sleep. Cortisol may be one of the things that can help, but the more primary defect is going to be the sleep issues. Signs of unrefreshing sleep, just the opposite of what it enhances. Poor performance at school or work, falling asleep, trouble making decisions, thinking about things. Definitely the fatigue and lack of energy, the moodiness causing problems with peers and spouses and et cetera. Fatigue can have the same effect as being drunk. This has been studied in doctors and et cetera. A doctor who is up 24 hours has had the equivalent of about 2 drinks. I may be incorrect in that, but the idea was basically you could almost hit an intoxicated limit with alcohol and function almost the same as somebody who's been up for 24 hours. So the interesting thing here is that nearly 70% said the doctor never asked me about sleep. It's a very important thing, yet it's highly ignored. So it is commonly remarked, things you should discuss with your doctor. It's common in children. It's common in children even without joint hypermobility, but at least 1/3 had some sleep disturbance. Many adults complain of it. Common in the connective tissue literature to have sleep issues. Restless legs could be one of those reasons. People have legs that sort of feel like things crawly, tingling. They feel like they need to move their legs. This was a study that we did as well. Looking at the questionnaire, we found 43% with moderate to severe restless leg syndrome, and yet most people were not aware of this, and many were never diagnosed. only 11% were diagnosed compared to the 43% that we found. Sleep study, this again looking at a number of people. So the global score, so more is worse here, 10 or 11 compared to controls. And if we look at other populations, basically chronic pain patients, very much in alignment. People with major depression, very much in alignment. People with fibromyalgia, very much in alignment. Worse than lupus, worse than cystic fibrosis, and yet, again, not considered much of a disorder, and people largely ignore the issues at EDS. Similar types of things here. This was another study that we did. The nice thing is we were able to compare it to fibromyalgia. So this is the sleep quality index, and you can see here are controls, here's fibromyalgia and EDS. Why is EDS under-recognized and fibromyalgia is considered more of a legitimate diagnosis when the issues are at least the same, if not greater? The cycle is the vicious cycle. Pain interferes with sleep, fatigue, mood, and they all interchange. So it's a very known set of things, constitutes what's called a chronic pain syndrome. That's where people have all of this, and it's somewhat expected. If you have all these things, we do expect sleep problems, mood problems, fatigue issues. And so, again, we're describing a set of symptoms related to people who have chronic pain, and now I think we're beginning to realize that this is a common pathway for fibromyalgia and multiple sclerosis and a number of different things. So hopefully together, looking at chronic pain, we'll get a better understanding not just of EDS, but of other things. Sleep management, I call it often disappointing. Multiple things, as I showed you before, sort of interact in there. Sometimes we make some good dents into the sleep is better and et cetera. We talk about sleep positioning. We talk about sleep hygiene. That's sort of controlling your sleep behavior. I talk about sort of a cool down routine. Get those muscles to relax. Get the body to relax, not just the mind. But cognitive behavioral therapy can help with the mind relaxing and those kinds of things. Medications can help, but medications, especially the sedative medicines, can be highly addictive. And so that's a worse side effect. So you're kind of tiptoeing around certain things, hoping that you make some changes to improve some sleep. But again, it's I won't call it trial and error, but you do have to try some things that are more likely to work, and when they're not making enough dent, you have to know what is tier 2, what is tier 3, and what's tier 4 treatment in order to help the patients. Dysautonomia. So there are a number of people who have orthostatic symptoms. That's where you stand up and you get sort of lightheaded, and syncope is actually when you faint. These are people that went to a hematology clinic, totally different than what we'd expect, like they're not rheumatology or whatever else. They pulled these from a clinic that wouldn't necessarily be enriched for this population and said, okay, you're in the hospital, by the way, you want to do this study. And the interesting thing is look at 5.5 times greater if you had fainting episodes, you had joint mobility syndrome. If you just complained dizziness, all the patients with joint mobility syndrome complained, but only 10% of the controls. So again, symptoms are there, people not asking the right questions, and therefore, if it's not recognized, there's no help offered. The whole thing is to get it recognized, and some of that empowerment is the teaching the patients what are the issues and how to communicate with your doctor so hopefully he or she can actually help. POTS is one of the forms of dysautonomia. There are other people who are going to be talking about this or already have on the EDS awareness site, so I won't go into it too much. There are particular definitions that you can sort of look at. When we look at POTS and joint hypermobility syndrome, there are a number of people who sort of have looked at these groups and can see that there is a distinct difference between people who have joint hypermobility and POTS versus the people who just have POTS. So there's something a little bit different about joint hypermobility syndrome. Cardiac manifestations, again, the formatting is really weird here. We spent 17 years looking at the aortic roots in EDS. primarily composed of classic and hypermobile EDS. So did the National Institute of Health. And basically we found 20 to 30% actually had a little bit of a generous dilation, but not to the point where we would ever clinically worry about them. We had the opportunity to follow up a number of patients over that 17 years and show that there was no progression. So they weren't getting dilated progressively over time, and therefore is one of those things that actually seems to be they're a little stretchy, but not too much. That's sort of the plot. I'll leave that for you to sort of look at. However, I will tell you that my recommendation for anybody with EDS is an echocardiogram. Now, many of my patients will go, what? He didn't say that for me. Mostly because, back to that Australian picture, is that you want to rule out some of those other syndromes. And if you're not comfortable making a diagnosis, look at every nook and cranny you can to make sure that you're putting the right label on them. Too many people get labeled with hypermobile EDS who might have other conditions, and we don't want to miss some of those other conditions. And we also want to make sure who has the label have it appropriately so we can treat them appropriately as well. So it's about bidding them or putting them in the right category. And I think an echocardiogram can definitely help. I can tell you some of my colleagues who do treat EDS, like Dr. Frank Amano, would get a baseline echocardiogram. Other people do not. I typically don't, but I can tell you many of my patients come with an echocardiogram anyhow. So it's a recommendation I put out there for others, but I don't necessarily adhere to that recommendation because I feel more comfortable with this disorder. Gastrointestinal system, this is one quick slide. Obviously, there can be a lot of problems from reflux to I feel full too early, hiatal hernia, gastroparesis, which may be dysautonomia, constipation, irritable bowel, prolapse. So there's a number of different things that can be related. The treatment sometimes is a little tincture of this, a little tincture of that. Fortunately, most people just manage. And I wish there was a better approach to this, but there's not. Fortunately, we are getting the people who specialize in GI and dysautonomia and on board, and they're starting to describe, they're starting to recognize it, so I'm hoping that we'll get more and more guidance here. Anxiety is also something very common. Basically, if we look at anxiety and people with joint hypermobility and panic disorder as a type, so basically it was more common in people with joint mobility as compared to controls. And the two other studies looked at the same thing and came with the same conclusion. So it's more common. The variability is at 7 or 10 or 14. So it's one of those things where anxiety, we know people who don't like to move because of problems or afraid that eventually will cause them pain during the day. This chronic pain cycle, sleep falls into that. So we talked about sleep, depression, but anxiety is also in here as well. You have increased pain, you kind of figure, oh, well, I did this, I'm worried about, well, I can't do that anymore because it caused me pain. The anxiety can affect sleep. It can affect how you look at things. You may decide to do less, that's socially or work or school. And anxiety can create, well, if I see the doctor, it's, more money, or I'm going to get therapy that doesn't help, and et cetera. So sometimes we have to treat that anxiety as well. Mast cell disorder, you saw at the very beginning of the announcement that the very next lecture through EDS awareness is on mast cell disorders. I'm not going to talk a lot simply because there isn't necessarily a lot out there specific to the EDS group. But I do recognize this in a small subset of my patients. Mast cells release histamine. It can be done by allergies or heat or chemicals or mechanical pressure. So a lot of things can trigger this. The nasty thing from the histamine is it can cause your vessels to dilate, which drops your blood pressure, which makes your POTS worse. It can cause your vessels to leak more fluid, causes your POTS to make worse. It causes increased fatigue because it lowers the blood pressure. That makes you feeling better. And it can cause some skin things. The problem is of how it's currently defined is very difficult. It is more typical to find the people who meet the definition who have mastocytosis, which is almost like a malignant disorder. So how do we appropriately, one, characterize, is this an issue in EDS, and then how do we diagnose it? I think it is something many of us are interested in, but we have yet to come up with a good plan of action here, other than some simple, what I call horse medicine. So I'm sorry, the last part was somewhat fast, trying to get through on time. We are on time, and this is my last slide. I know this will be available for other people to view and et cetera. So if, unfortunately, I sort of breeze through some things, you'll have a chance to go look at it tomorrow and read through the slides and get more information. Thank you very much.
That was fantastic, Dr. Tinkle, and so much information. I know we kind of rushed you towards the end, but you covered many, many bases, and we really appreciate that. Most of us are getting piecemeal information, and this was, boy, a complete package, and I'm getting feedback from many people that are indicating that they thank you very much, and very good program, and Dr. Tinkle knows everything. There's a lot of good feedback here. So we certainly appreciate all the work that you put into this program and summarizing it for us so that we have a better picture of the overall complexity and the understanding that we need to have of the Ehlers-Danlos syndrome. So do you have any final comments, Dr. Tinkle?
Well, obviously I tried to sort of do a bit of an overview, and unfortunately a lot of these topics are very superficial. So thank you, John, for providing not only the venue for me to do this, but to drill down in those particular topics where we can look in deeper, just like the next talks being on mast cell disorders, where they are, how they work, what are simple management strategies, and et cetera, to get a better understanding of what these are. How we put those in context of EDS sometimes is the missing question, and I'm hoping that, again, as we're talking across multiple disciplines and et cetera, we're recognizing EDS is not a genetic disorder. It's a rheumatologic, it's an orthopedic disorder, it's a GI disorder, it's, you name it, and everybody's involved in this disorder. And the more we talk about these issues, especially across disciplines, I am hoping that we will have much more empowerment from the healthcare community to work on these problems. So I think it's an exciting time, but I know it's frustrating for a lot of people, who want answers. But it really has changed over the last few years of what's really being talked about in EDS.
Fabulous. Thank you very much. And I just want to remind you again that on June 2nd, we have another webinar, and that will be on mast cell activation. And also, we encourage you the month of May, get out and do some awareness activities. Let us know what those are, because we'd like to have a running report of all those activities. If you'd like to get some shirts we have some really nice zebra shirts out on our site that you can buy for $10 during those activities. And Body Support Store is a sponsor for this program, so please go out and look at the items that we have for sale. And those items are selected by EDSers for EDSers. So I think we had a record number of attendees here, and we're really excited about that. And we appreciate your patience all the way through the end. So the recording will be on our site tomorrow, as well as the slides. So we'll call it evening. So thanks again for joining us. Good night.